Imagine waking up every 2 minutes, entirely convinced that you have, well, just emerged from a years-long coma.
It is a genuinely terrifying concept.
Right. You look around the room, and everything seems startlingly new. You write in a journal, "I have finally woken up." But a minute later, you blink, and the world just resets.
The slate is wiped entirely clean.
Exactly. You look at the journal, you see the handwriting, you recognize it as your own, but you have absolutely no memory of writing it. So you cross it out and write again, "Now I am truly awake."
And this wasn't a thought experiment or, a science fiction script. This was the actual daily reality for a man named Clive Waring.
It's astonishing. And it forces us to really confront a profound reality about the field of psychiatry. We are essentially looking at the study of how brain, mind, and experience interact, and crucially, how that intricate process can go just disastrously wrong.
It is a very delicate, almost precarious interplay, isn't it? You have the biological machinery of the neurons, the subjective cognitive experience of the individual, and the environmental context. All of these are constantly shaping what we perceive as reality.
Yeah, and when a single piece of that machinery is altered, the entire construct of reality can shift.
Spot on. The entire foundation wobbles.
And to really understand how psychiatrists map that shift, I want you, the listener, to imagine Medlock Holmes returning once more to the great library of the mind.
I like this analogy. It sets the stage perfectly.
Right, because unlike cases of severe late-stage dementia where, say, the library's roof is caved in and the books are rotting, this library is still functioning remarkably well.
The catalog remains largely intact.
Yes, visitors are still finding most of the books they need, the librarians are continuing their daily work, and the building itself is fully operational.
I mean, to a casual observer walking past the front steps, absolutely nothing is amiss. The lights are on, the doors are open.
But Holmes, with his magnifying glass, he notices the subtle, insidious shifts. A librarian takes just a little longer to locate a familiar volume. A catalog entry subtly requires a second, maybe a third search. A book is occasionally misplaced, left on the wrong cart, lost in the stacks, before eventually being found again.
The library continues to function, yes, but it operates without that effortless efficiency it once possessed.
Exactly, and that visual perfectly encapsulates the world of mild cognitive impairment, or MCI.
It really is the liminal space. The machinery is catching just a little bit, but the system hasn't failed.
And that is our mission for this deep dive. We are exploring the transitional territory between normal cognitive aging and major neurocognitive disorder.
Which is a vast and incredibly nuanced territory.
It really is. We will be looking specifically at mild cognitive impairment and its highly specific subset, amnestic disorders. And we're going to do this by moving structurally from mechanism to manifestation to clinical meaning. We want to integrate the raw neuroscience with the clinical reasoning to help you build robust mental models of how psychiatrists actually think about memory and cognitive decline.
Because we're not just regurgitating textbook facts here. We're building a conceptual synthesis.
Absolutely. Okay, let's unpack this, starting with the borders of normalcy. Because fundamentally, aging itself is not a disease, is it?
No, it is not. Though historically and certainly culturally, we often struggle to separate the two. I mean, the brain ages just like the cardiovascular system or the musculoskeletal system.
The actual biological substrate naturally changes.
Precisely. The myelin sheaths insulating your neurons, they might thin slightly. Synaptic density decreases.
So clinically, what does that actually look like for someone?
Well, it might take you longer to retrieve the name of that specific character from a novel you read, say, 10 years ago.
Right. The word is on the tip of your tongue, but the retrieval is just slower.
Exactly. Or new information, like a complex new software program at work, it might require a bit more repetition to stick. Your baseline processing speed slows down slightly.
But all of these changes are entirely expected. They're measurable and normal in a healthy aging brain.
They are. So the real challenge for a clinician sitting across from a patient isn't just noticing a slow librarian.
Right. It's figuring out when that librarian is just older versus when they are actually showing the early signs of a systemic failure.
That is the crux of the diagnostic dilemma. And, the medical field struggled for decades to define this highly imprecise border.
Yeah, I saw in the sources, if we look back to the early 1960s, specifically a paper by Kroll in 1962, we see the first real attempts to categorize this.
Right, Krall introduced two distinct terms for older adults experiencing memory issues. He called them benign senescent forgetfulness and malignant senescent forgetfulness.
I have to say, malignant sounds incredibly intense for a memory issue. You hear malignant, you think oncology, you think cancer spreading.
It was a very stark choice of words, I agree. But Kralls was trying to separate the clinical prognosis.
Okay, how so?
Well, benign senescent forgetfulness meant the patient had trouble recalling relatively unimportant facts or, say, details of an experience, but crucially, they retained insight.
Ah, they had awareness of their problem.
Exactly. They would come in and say, "Doctor, my memory just isn't what it used to be."
And the malignant version.
Malignant, on the other hand, involved profound memory problems for recent important events, coupled with a distinct lack of awareness.
They didn't realize the memory was gone.
Right, and that lack of insight was highly predictive of a rapid progression to severe dementia.
I mean, I see the utility in that, but the terminology kept evolving, didn't it? I noticed the National Institute of Mental Health tried to rebrand this in the late 1980s.
Yes, they introduced the term age-associated memory impairment.
But that immediately ran into controversy, right? Regarding how they were actually benchmarking the data.
The methodology was inherently flawed from a statistical standpoint. I mean, to diagnose this age-associated memory impairment, researchers were taking the cognitive test scores of adults over 50 and comparing them against the normative data of healthy 20-something-year-olds.
That just feels absurd. Isn't that like comparing the top speed of a vintage, well-maintained 1960s Jaguar to a brand new electric sports car, and if the Jaguar is slower, diagnosing it as broken?
That is a highly accurate way to frame the statistical error. You simply cannot benchmark an 80-year-old brain against a 20-year-old brain to define a pathological disease state.
Because a standard deviation below a 20-year-old's mean is often perfectly normal for an octogenarian.
Precisely. And realizing this, the conceptual evolution eventually led us to the modern, far more rigorous definition found in the DSM-V.
Which relies on the term mild neurocognitive disorder.
Yes. That acts as the formal clinical umbrella, capturing what we colloquially call mild cognitive impairment.
So where is the boundary then? In the DSM-V, where do psychiatrists draw the line in the sand between the vintage Jaguar and the broken engine?
The defining criteria for mild neurocognitive disorder rest on two primary pillars. The first pillar is that there must be evidence of a modest cognitive decline from a previous level of performance.
And this isn't just about memory, is it?
No, not at all. It can manifest in one or more cognitive domains. So, complex attention, executive function, learning and memory, language, perceptual motor skills, or even social cognition.
But that decline has to be objective. It can't just be a patient sitting in the clinic saying, "I feel a bit foggy lately."
Well, subjective concern is the starting point. It usually begins with a concern expressed by the individual, or maybe a knowledgeable informant like a spouse, or even the clinician observing them.
Right.
But that subjective complaint must then be documented and quantified. We rely on standardized neuropsychological testing to prove that the decline is mathematically real compared to norms for their specific age and education level.
Okay, so that's the first pillar, objective decline. What's the second?
It's the second pillar that is the most critical for clinical reasoning. It is the defining line. These documented cognitive deficits must not interfere with the capacity for independence in everyday activities.
Let me bring back the library metaphor here to really test that line.
Please do.
So, if our librarian is leaving post-itched, it notes absolutely everywhere just to keep the library running. Taping them to the shelves, setting alarms on their watch to remember to lock the doors, keeping a meticulously color-coded ledger just to track the incoming books.
Right.
The library is technically still independent. The doors are opening on time. The books are circulating. But the system is straining heavily under the weight of that effort. Is that mild neurocognitive disorder?
Yes. That is the perfect illustration of compensatory behavior.
Oh, interesting.
Complex instrumental activities of daily living things like managing a multi-pill medication regimen, handling complex finances, or navigating a new driving route, they are preserved. The patient is still succeeding at the task.
But it requires significantly greater effort.
Exactly. Greater effort, new compensatory strategies, or environmental accommodation.
But I have to push back on the practicality of that. I mean, how on earth does a clinician objectively measure effort in a standard 45-minute consultation?
It's challenging.
If a patient is sitting in your office, immaculately dressed, highly articulate, and their independence is completely preserved on paper, How do you differentiate between an anxious 70-year-old experiencing normal aging and someone who is truly crossing the border into MCI?
That distinction is exactly where the art and science of psychiatry merge. You cannot simply ask a yes or no question like, are you still paying your bills?
Because they'll just say yes.
Right. You have to act like Medlock Holmes and ask how they are paying their bills. You turn to the spouse and ask, have you subtly taken over balancing the checkbook because there were suddenly unexplained late fees last year?
Looking for the safety net.
Exactly. Did you have to purchase one of those automated, alarm-based pill dispensers because you noticed double dosing? The independence is often a facade propped up by the environment.
So the independence isn't absolute, it's heavily scaffolded.
Heavily scaffolded. And to get to your point about objective measurement in a short clinic visit, this is why the choice of screening tool is absolutely paramount.
Let's talk about the screening tools.
For decades, the field relied on the Mini Mental State Examination, or MMSE, but the MMSE is actually quite insensitive for detecting the subtle nuances of MCI.
So the MMSE is basically just checking if the library is currently on fire, but it doesn't check if the catalog is disorganized.
Essentially, yes. The MMSE is heavily weighted towards basic orientation, asking the year, the season, the city, and basic language.
Which an early MCI patient could breeze through.
Exactly. An intelligent, highly educated patient with early MCI will easily score a perfect 30 out of 30 on the MMSE. They can mask their deficits.
So what's the alternative?
This is why most clinicians now prefer the Montreal Cognitive Assessment, the MoCA. The MoCA stresses the frontal lobes and executive function much, much harder.
How does it do that?
It includes a trail-making test where the patient has to alternate between numbers and letters in sequence 1A, 2B, 3C, and so on, and a task requiring them to draw a three-dimensional cube.
Which demands a lot more processing power.
Precisely. It demands working memory, planning, and visuospatial processing. Those are the exact domains that begin to strain when a patient is putting in that extra effort to maintain their daily independence.
Okay, so if the MoCA reveals those cracks in the facade, what is actually happening underneath? Because this is where the field is currently undergoing a massive seismic shift.
It really is.
If the clinical presentations is just the tip of the iceberg, what is happening down in the deep biology?
The shift you are referring to is one of the most profound paradigm changes in modern neurology and psychiatry. For over a century, since Alois Alzheimer first described his eponymous disease in 1906, we defined these cognitive disorders purely as syndromal constructs.
Meaning the disease was defined entirely by the clinical symptoms the patient exhibited.
Right. If you had progressive memory loss that eventually impaired your daily function, you had Alzheimer's disease. But in 2018, the National Institute on Aging and the Alzheimer's Association, the NIA, proposed a radical departure.
What do they propose?
They proposed defining the disease biologically.
Wow. Defining it by the microscopic proteins physically present in the brain tissue, regardless of whether the patient is showing outward symptoms or not.
Precisely. They argued that Alzheimer's is not just a set of symptoms, it is a specific biological cascade. And to codify this, they introduced the ATN framework, ATNN.
So it categorizes the measurable biomarkers into three distinct groups. Let's unpack the ATN model thoroughly because this is foundational.
Absolutely.
The A stands for amyloid. What is the mechanism here?
The A measures the presence of beta amyloid plaques. To really understand this, we have to look closely at the neuronal membrane. Normally, you have a protein called amyloid precursor protein, or APP, sitting right in the cell membrane. It gets routinely cut up by cellular enzymes called secretases.
Just standard cellular maintenance.
Exactly. But in this disease process, beta and gamma secretases cleave the APP in a very specific, abnormal way, creating a sticky, insoluble fragment known as a beta 42.
And these are the fragments that clump together.
Yes, they clump together outside the neurons, forming those toxic plaques.
But how do we actually measure that in a living patient? Because I was looking at the source material, and it noted a diagnostic criteria of finding low levels of A-beta 42 in the cerebrospinal fluid, the CSF.
Yes.
That seems entirely counterintuitive. If the brain is rapidly building up toxic amyloid plaques, why on earth are the levels in the spinal fluid low?
It is a brilliant paradox, isn't it?
Right.
But it makes perfect mechanical sense when you visualize it. The amyloid fragments are highly sticky.
Right.
Because they are aggregating and binding together to form dense plaques within the actual brain tissue, they are effectively trapped there. They precipitate out of the solution.
Oh, I see. Therefore, less of the free-floating beta 42 is able to circulate out of the brain and wash into the cerebrospinal fluid.
Exactly. Low CSF amyloid means high brain amyloid. It's a reverse indicator. Alternatively, we can bypass the fluid entirely and use an amyloid PE scan.
How does that work?
We inject a radioactive tracer that binds specifically to these plaques, allowing us to visualize the amyloid burden literally glowing on the scan of a living brain.
Okay, so A is amyloid, the sticky plaques outside the cell. The T in the framework stands for tau. How does tau differ from amyloid?
If amyloid is the pathology outside the neuron, tau is the pathology inside the neuron.
Okay.
Now, tau is normally a very helpful essential protein. Inside a healthy neuron, there is a network of microtubules, essentially a microscopic railway system that transports nutrients and cellular machinery from the cell body all the way down the long axon.
And what does tau do in that railway system?
Tau acts like the wooden ties holding the rails together, stabilizing the entire structure.
So what causes the tracks to fall apart?
The tau protein becomes hyperphosphorylated, too many phosphate groups attached to it. When this happens, the tau detaches from the microtubules.
The ties are removed.
Exactly. The ties are removed and the railway tracks collapse, completely starving the neuron. Furthermore, those detached tau proteins then clump together into neurofibrillary tangles.
And those tangles physically choke the internal machinery of the cell.
They do. We measure this biological catastrophe by finding increased levels of phosphorylated tau, or p-tau, in the CSF, or by using a specific tau PIT scan.
Which brings us to the final letter, the N in parentheses.
Right. N stands for neurodegeneration. This is the downstream result of the first two. It is the actual structural death of the neurons.
And we can see this physically happening, right?
Yes, through several modalities. We can see it structurally as atrophy or brain shrinkage on a high-resolution MRI.
Like the physical volume of the brain decreases.
Precisely. We can also see it metabolically on an FDG PET scan. FDG is essentially radioactive glucose. Since dying neurons don't consume energy, an FDG PET scan will show hypometabolism, dark, quiet areas of the brain that are no longer burning glucose.
And is there a fluid biomarker for the N?
Yes. Finally, we can detect neurodegeneration by finding elevated total tau in the CSF. Not phosphorylated tau, just total tau.
Wait, why does total tau indicate death? Specifically?
Because when a neuron undergoes apoptosis, when it physically dies and its cell membrane ruptures, it spills all of its internal contents out into the surrounding fluid. A high level of total tau in the CSF is essentially the chemical debris field of shattered neurons.
Wow. This framework is incredibly elegant. ATN, amyloid, tau, neurodegeneration.
It provides a very clear biological timeline.
And this is a massive, but here is where the clinical reality violently collides with the biological theory.
Yes, it does.
The sources highlight some incredibly puzzling realities when we actually start applying these biomarkers to living, breathing people. You can take a patient with mild cognitive impairment, put them in a PET scanner, and find an amyloid burden that is completely identical to a patient locked in a memory care unit with severe end-stage Alzheimer's dementia.
That is true.
And yet, our MCI patient is still driving a car and cooking dinner.
The clinical field refers to this as the paradox of plaque. The mere presence and burden of amyloid does not perfectly correlate with the patient's clinical stage.
Which is mind-boggling.
It is. You can have MCI subjects with control-like minimal levels of amyloid, and you can have completely cognitively normal individuals walking around with severe Alzheimer's-like levels of amyloid in their brains.
That feels like it shatters the simple cause and effect model we've been taught. If amyloid is the singular villain that causes dementia, why are some people with brains full of amyloid still balancing their checkbooks?
This is exactly what longitudinal observational studies, particularly the massive cohorts, followed by places like the Mayo Clinic, sought to answer.
And what did they find?
They found that the different ATN markers drive vastly different clinical trajectories. If an MCI patient has a positive A marker, just the amyloid, their cognitive decline is usually remarkably slow. They might remain stable for years, even decades.
Okay, so the amyloid alone is slow.
Yes. However, if they have a positive N marker active neurodegeneration, where neurons are actually dying, they progress to clinical dementia rapidly.
Which leads us to a concept in the sources that completely threw me. SNAP, suspected non-Alzheimer pathology. What exactly are we suspecting here?
SNAP is the scenario that keeps researchers up at night. They began finding patients with clear, mild cognitive impairment whose MRI scans showed devastating neurodegeneration, but whose amyloid PE scans were entirely negative.
Wait, they were declining cognitively, their memory was fracturing, their brains were physically shrinking.
Yes.
But the classic hallmark of Alzheimer's, the amyloid plaque, was completely absent.
Completely absent.
So if there is no amyloid to trigger the tau tangles, what is destroying the library? Who is the unseen arsonist?
In many of these cases, the unseen arsonist turned out to be a relatively newly defined diagnostic entity called LATE.
LATE.
Yes, stands for limbic predominant age-related TDP-43 encephalopathy.
Limbic predominant age-related TDP-43 encephalopathy. Let's break down the mechanism of LATE because this really highlights why the biological framework is so necessary. What is TDP-43?
To understand LATE, we must look at a totally different protein. TDP-43 stands for TAR DNA binding protein 43. In a healthy, normal cell, TDP-43 lives safely inside the nucleus. Its primary job is to regulate RNA splicing.
So what does that mean in practice?
It acts like a meticulous editor, ensuring the genetic instructions are cut and pasted correctly before they are sent out into the cell to build proteins.
So it's essentially a factory manager staying in the control room.
Exactly. But in the pathology of LATE, the factory manager goes rogue. The TDP-43 protein misfolds, escapes the nucleus, and aggregates into dense, toxic clumps in the cytoplasm of the cell.
Stripped of its editor, the cell's internal genetic machinery just begins to produce flawed proteins.
Right, and the sheer physical mass of the misfolded TDP-43 clumps physically chokes the neuron to death.
And where in the brain does this specific protein misfolding happen?
The name gives it away. Limbic predominant. It heavily attacks the limbic system, particularly causing severe sclerosis or scarring in the hippocampus.
And who does this affect mostly?
It is typically a disease of the oldest old, usually emerging in patients well over the age of 80.
But if I am a clinician observing this patient from the outside, without the benefit of a brain biopsy, what does LATE actually look like?
That is the cruel irony of the disease. Clinically, LATE presents exactly like an amnestic dementia syndrome.
Oh, wow.
The progressive memory loss, the functional decline, it mimics Alzheimer's disease perfectly. A clinician relying solely on syndromal observation would diagnose it as Alzheimer's almost every single time.
But the underlying biological mechanism is entirely fundamentally different.
Exactly.
Which forces me to ask the so what question.
Yeah.
If I am a patient sitting in a psychiatry clinic with mild cognitive impairment, does classifying me biologically with the ATN framework rather than just syndromally actually change my clinical outcome today?
That is the vital, intensely debated question in modern psychiatry. When the NIA proposed this framework, they explicitly stated it was intended for research use to thoroughly validate the biomarkers.
So not for everyday clinical use yet.
Right. In everyday community clinical practice right now, we still heavily rely on the clinical syndromal diagnosis. However, this biological understanding has fundamentally shifted our conceptual model. It tells us unequivocally that beta amyloid is considered necessary but not sufficient to produce the Alzheimer's syndrome.
I really want to highlight that phrase, necessary but not sufficient, meaning you need the amyloid plaques to start the initial cascade, but the amyloid alone isn't what ultimately destroys the library.
Correct.
It's the subsequent tau tangles and the rapid neurodegeneration that actually cause the clinical symptoms of memory loss.
That is the prevailing model. The amyloid is the match, dropped in the library. It might smolder for a decade, but the tau tangles and neurodegeneration are the roaring fire that actually burns down the shelves.
And identifying these distinct biomarkers, separating an amyloid patient from a LATE patient, why does that matter so much moving forward?
Because it's becoming progressively more critical as highly targeted, disease-modifying treatments enter the market. If you have a multi-million-dollar monoclonal antibody drug designed specifically to clear amyloid plaques from the brain,
it's going to be completely useless for a LATE patient.
Exactly. It would be entirely useless and potentially harmful to give it to an 85-year-old whose dementia is actually being driven by TDP-43 clumps. The biology dictates the therapy.
That perfectly bridges us from the deep microscopic biology to the macroscopic clinical manifestations.
Yeah.
When we talk about MCI in a clinical setting, we are not talking about a monolith. There are distinct clinical subtypes.
Yes, very distinct.
And these subtypes act as a sort of predictive matrix for what kind of dementia a patient might eventually develop. Let's trace these pathways.
Clinical subtyping is a core skill for any psychiatrist. We broadly divide MCI into two main branches, amnestic and non-amnestic.
Right.
Amnestic means the core deficit is memory. Non-amnestic means memory is relatively preserved, but another cognitive domain like language, visuospatial skills, or executive function is primarily impaired.
And from those two branches, we subdivide further into single domain or multiple domain.
Let's start with amnestic MCI, single domain. This means only your memory is objectively impaired on testing. Everything else, your language, your attention, is pristine.
And where does this pathway usually lead?
This specific subtype has a very high, predictable likelihood of progressing to classic Alzheimer's disease. It is the textbook prodromal phase.
What if it's amnestic MCI, multiple domain? So memory is failing, but they are also struggling with, say, executive function, like planning a sequence of events.
That presentation broadens the differential. They are still at high risk for progressing to Alzheimer's, but the addition of executive dysfunction also raises a significant risk for vascular dementia.
Vascular dementia.
Yes, often driven by underlying microvascular ischemic disease, essentially tiny silent strokes accumulating in the white matter over years.
Now let's look at the non-memory folks, the ones whose hippocampus seems fine, but other systems are breaking.
If a patient has non-amnestic MCI, single domain, let's say their memory is perfect, but they have profound progressive difficulty finding the right words, or their personality is undergoing strange impulsive shifts.
What does that predict?
That presentation frequently progresses to frontotemporal dementia, or FTD. The pathology is entirely avoiding the memory centers and attacking the frontal or temporal lobes.
And finally, non-amnestic MCI, multiple domain.
A combination of non-memory deficits, perhaps severe fluctuations in attention, coupled with visuospatial problems like getting lost in familiar places. This often progresses to dementia with Lewy bodies, or DLB.
Are there other signs for DLB?
Yes, you might also start to see the early signs of Parkinsonism or visual hallucinations in these patients.
It truly is a clinical roadmap. But for the remainder of this deep dive, I want us to zoom in on one specific wing of the library. The highly specialized, delicate archive responsible for memory formation and retrieval. The amnestic disorders.
A fascinating area.
Because the psychiatric diagnosis of an amnestic disorder requires a very specific, pure memory deficit that does not warrant a full, broad dementia diagnosis.
Amnestic disorders are clinically fascinating precisely because of their sheer selectivity. The surrounding cognitive architecture remains robust while the memory apparatus specifically fails.
What's the core symptom?
The defining core symptom of an amnestic disorder is a profound inability to learn new information. Clinically, we call this anterograde amnesia. The patient cannot convert short-term working memory into long-term storage.
But it's not just the new information, is it? It works backwards as well.
Correct. You also frequently see an inability to recall previously learned information, which is retrograde amnesia.
And the fascinating thing about retrograde amnesia is that it doesn't wipe the hard drive evenly. It is almost always temporally graded. We call this Rubbo's law in neurology.
Yes.
Meaning the remote memories, the patient's childhood, their early adulthood, their wedding day, survive much, much better than the recent memories from last month or last year.
And the mechanism behind Rubbo's law speaks to how the brain consolidates data.
How does that work?
When a memory is newly formed, it relies heavily on the fragile circuitry of the hippocampus. But over time, through a process of consolidation that often happens during sleep, that memory is distributed and hardwired into the broader, more resilient neocortex.
So it moves from fragile storage to stable storage.
Exactly. The older the memory, the less it relies on the hippocampus to be retrieved. So when a disease damages the hippocampus, the recent unconsolidated memories are wiped out, but the old cortical memories endure.
But crucially, in a pure amnestic disorder, what functions remain totally intact?
This is how you differentiate it from a broader dementia. Immediate recall remains intact.
So if you give them a quick task.
Right. If I ask an amnestic patient to repeat the numbers 7294 immediately back to me, they can do it flawlessly because that relies on the frontal lobe's working memory, not the hippocampus. Their attention span is entirely normal.
And there's another type of memory that survives too, right?
Most remarkably, their implicit memory, which includes procedural learning and motor skills, is completely preserved.
To really anchor this in clinical reality, we have to return to the man we introduced at the very beginning of the show. One of the most profound and widely studied case studies in the history of neuropsychology, Clive Waring.
Clive Waring's narrative is a tragic but illuminating masterclass in the neuroanatomy of memory. He was a highly accomplished British musicologist and conductor. In 1985, he contracted herpes simplex encephalitis.
The herpes virus, a common virus, but in his case, it crossed the blood-brain barrier. And the textbook sources note a very specific anatomical affinity here. Herpes encephalitis preferentially attacks the brain via the olfactory and trigeminal nerve pathways, leading it directly into the limbic system. It causes severe hemorrhagic necrosis,
which literally translates to tissue death accompanied by massive bleeding,
specifically targeting the medial temporal lobes.
which is precisely where the hippocampia reside. The bilateral destruction of his temporal lobes resulted in an anterograde amnesia so severe it is almost difficult to conceptualize.
But his other faculties were fine.
Waring's perception of the world was entirely unimpaired. He could see clearly, hear perfectly, and hold a highly intelligent conversation in the present moment. His intelligence quotient remained high.
But his retention window,
Yeah.
the duration for which he could hold a piece of information,
Yeah.
limited to a matter of seconds. Literally the length of a blink.
It's astounding.
His wife described his daily existence as feeling like a film with terrible continuity editing. He would blink, look away, and to his internal experience, the scene had entirely reset. He lived in an eternal, isolated present tense, constantly gripped by the terrifying sensation of having just woken from a deep coma.
His explicit episodic memory, the system that records the episodes of our lives, the what, where, and when, was entirely eradicated by the viral necrosis, but, and this is the vital clinical distinction, his implicit memory survived untouched.
Here's where it gets really interesting, and I want to bring back our library analogy to explain this. Explicit memory, the episodic facts and events of your life, are the books inside the library, the records of experiences.
Right.
Implicit memory or procedural memory is the physical architecture of the building itself, the staircases, the corridors, the structural pathways, the muscle memory of how to navigate the space.
That is a highly precise way to conceptualize the distinct neuroanatomical systems.
So in Clive Waring's case, the viral encephalitis destroyed the librarians and the catalogue. Every single new book that arrives at the library is instantly incinerated. His explicit memory fails completely.
He cannot tell you what he had for breakfast. He cannot tell you if he has seen you before.
But the physical building is still perfectly navigable.
Mm-hmm.
He could still sit down at a piano, look at complex sheet music, and play a piece flawlessly. He could direct a choir. His implicit memory of how to play the piano was perfectly preserved, even though if you asked him if he had ever seen a piano before in his life, he would genuinely say no.
It shatters the colloquial notion that memory is a single filing cabinet located in one spot in the brain. It proves that memory is a highly diverse, distributed network of independent systems.
The structures are completely distinct.
Yes. The medial temporal lobes and hippocampi are absolutely necessary for creating explicit declarative memory, but the basal ganglia and the cerebellum, which orchestrate procedural motor memory, were completely untouched by the herpes virus. The piano pathways survived.
Herpes encephalitis is a dramatic infectious cause. But let's move into our integration and clinical reasoning section and map out the other major etiologies, the underlying causes of these amnestic disorders. We broadly divide them into primary brain conditions and systemic metabolic conditions.
Looking at primary brain conditions, traumatic brain injury, or TBI, is clinically the fastest growing cause of amnestic disorders, given the rates of motor vehicle accidents and contact sports.
What about vascular causes?
We frequently see amnestic syndromes resulting from specific cerebrovascular events, strokes, specifically strokes that occlude the posterior cerebral artery because that artery supplies the vital blood flow to the medial temporal lobes.
The sources also place heavy emphasis on anoxia, or profound lack of oxygen to the brain.
Anoxic brain injuries, whether from cardiac arrest, near drowning, or carbon monoxide poisoning, are devastating to the memory circuitry. The hippocampus, specifically a tiny subregion known as the CA1 sector, historically called Summers sector, is exquisitely sensitive to metabolic compromise.
Why is that specific sector so fragile? It's like the server room of our library, isn't it? It requires the most power and the most cooling, so if the power grid fails for even 3 minutes, the servers melt down first.
Exactly. The CA1 pyramidal neurons have an exceptionally high metabolic demand. When oxygen and glucose are cut off during a cardiac arrest, those neurons are often the very first cells in the entire brain to undergo necrosis.
So they just die immediately.
Right. A patient might be resuscitated and wake up with perfect motor function, but with a permanent, profound anterograde amnesia simply because Summers sector died.
And then we shift to the systemic metabolic conditions, hypoglycemia, substance-induced amnesia. But the absolute heavy hitter here, the condition that is heavily tested on board exams and is vital for any clinician to recognize immediately, is Wernicke-Korsakoff syndrome. Let's take this from microscopic mechanism all the way up to clinical manifestation.
Wernicke-Korsakoff syndrome is a classic, essential clinical entity. Fundamentally, it is a disease driven by the profound deficiency of a single molecule, thiamine, also known as vitamin B1.
And in the developed world, this deficiency is overwhelmingly driven by chronic, severe alcohol use disorder. But I want to be precise here. It's not just that chronic alcoholics might have a poor diet, replacing food calories with alcohol calories, though malnutrition certainly plays a role.
No, it's much more direct than that.
Alcohol actively wages war on thiamine through multiple biological pathways.
It is a multi-hit biological assault. First, chronic alcohol consumption actively reduces the body's levels of folate. A folate deficiency directly and mechanically impairs the enterocytes in the gastrointestinal tract from absorbing whatever thiamine the patient actually manages to consume.
So it blocks absorption at the door.
Yes. Furthermore, the alcohol itself causes direct cytotoxic damage to the intestinal mucosa, destroying the absorption architecture. And finally, alcohol impairs the liver's ability to store thiamine and convert it into its active form.
So even if the patient eats a vitamin-rich meal, their gut cannot absorb the B1 and their liver cannot process it. But why is thiamine the linchpin? Why is it so vitally important to the brain's survival?
Because thiamine crosses the blood-brain barrier and must be phosphorylated into its active form. Thiamine pyrophosphate, or TPP.
Okay, TPP.
Now, TPP is not just a passive vitamin. It is a vital enzymatic cofactor required for 3 critical enzymes that drive glucose metabolism: transketolase, pyruvate dehydrogenase, and alpha-ketoglutarate dehydrogenase.
That's the Krebs cycle, right?
Exactly. These enzymes are the engine of the Krebs cycle. Without TPP, the brain's neurons literally cannot metabolize glucose to produce ATP.
The power grid fails. The brain's fuel supply is cut off at the cellular level.
The energy failure triggers a catastrophic biochemical cascade. TPP is also crucial for the synthesis of vital neurotransmitters, specifically acetylcholine, GABA, and glutamate.
So what happens when the energy stops?
When the neuronal power grid fails, we see selective cell death. Extracellular glutamate, an excitatory neurotransmitter, begins to pool and build up to toxic levels because the energy-starved cells cannot pump it away.
And what does that excess glutamate do?
This excess glutamate chronically opens NMDA receptors, allowing massive amounts of calcium to flood into the neurons.
Like opening the floodgates.
Exactly. This calcium influx triggers what we call NMDA receptor-mediated excitotoxicity. The neurons literally fire themselves to death in a state of hyperexcitability. This is accompanied by a massive spike in oxidative stress, the generation of free radicals, and ultimately irreversible neuronal necrosis.
And this widespread systemic metabolic disaster doesn't just damage the brain evenly, does it? It targets highly specific, highly vulnerable anatomical structures.
The pathology localizes. The hallmark lesions of chronic Korsakoff syndrome are found in the diencephalon. Specifically, if you perform an MRI or an autopsy, you will see profound atrophy, necrosis, and microhemorrhages in the mammillary bodies, the fornix, and the medial dorsal nuclei of the thalamus.
So we have mapped the mechanism and the microscopic damage. What is the clinical meaning? If a Korsakoff patient walks into the clinic, how do they manifest differently from a patient with Alzheimer's or herpes encephalitis?
They will present with a profound, debilitating anterograde amnesia, the inability to form new memories. However, what uniquely distinguishes diencephalic amnesia, like Korsakoff syndrome, from a pure hippocampal amnesia, like Clive-Wearing, is the presence of a fascinating psychiatric symptom called confabulation.
Confabulation. The spontaneous production of false memories. They invent elaborate stories to fill the gaping holes in their memory.
They do.
And I want to put you on this because the textbook touches on it and it's philosophically fascinating. What is the actual nature of confabulation? Is it merely a psychological defense mechanism? Is the patient just embarrassed that their mental catalog is broken so they consciously or subconsciously make something up to save face in front of the doctor? Or is it a primary, hardwired neurological misfiring generated by the damage to the diencephalon itself?
That specific question has been a subject of intense debate among neuropsychiatrists for decades. Historically, earlier in the 20th century, it was viewed almost entirely through a psychodynamic lens, exactly as you described, as a psychological attempt to cover the deficit and maintain ego integrity.
But our understanding has evolved.
Yes, modern neurology leans heavily toward it being a primary neurological deficit. The damage to the medial dorsal thalamus disrupts critical circuits connecting to the frontal lobes. This frontal diencephalic network is responsible for the brain's reality monitoring system.
Reality monitoring, the system that puts a timestamp and a context tag on our memories. So when they confabulate, they aren't lying. Their brain is genuinely serving up a fabricated or chronologically misplaced memory and presenting it to their consciousness as the absolute truth.
Precisely. They might tell you with absolute unshakable conviction that they just got back from a walk in the park with their dog, when in reality they have been confined to a hospital bed for 3 months.
The patient has no awareness that they are.
That they're actually confabulating, right? The brain is fetching a real memory fragment from perhaps a decade ago, but the frontal checking mechanism is broken. It fails to suppress irrelevant associations, so the patient truly deeply believes the confabulation. It is a hallmark of Korsakoff syndrome, far more frequent than in pure temporal lobe damage.
Okay, so we've mapped the intricate damage of these disorders. Let's talk about the clinical horizon, treatment and prognosis. Because a massive overarching theme in this chapter is the sheer weight of clinical uncertainty.
Uncertainty is the defining characteristic of treating mild cognitive impairment and amnestic disorders. Let's look at Wernicke-Korsakoff. It is a biphasic illness.
Meaning there are 2 distinct phases.
Right. If a clinician catches the patient in the acute early phase, known as Wernicke's encephalopathy, characterized by the classic triad of confusion, ataxia, which is a stumbling gait, and ophthalmoplegia, or paralysis of eye movements, and immediately administers high-dose intravenous thiamine, the cascade can be halted.
So it's reversible at that point.
The confusion and eye paralysis might reverse entirely. But if it goes untreated and settles into the chronic Korsakoff amnesia phase, the damage is largely done. Even with thiamine replacement, only about 25% of patients will see significant cognitive recovery. The vast majority are left with permanent, institutionalizing memory impairment.
And we see that exact same theme of uncertainty when counseling a patient regarding the progression of mild cognitive impairment to Alzheimer's disease. The conversion rates are not absolute. They vary wildly depending on the cohort, generally hovering around 10 to 15% progression per year.
And importantly for clinicians to communicate, it is not a strictly one-way street. A significant percentage of people diagnosed with MCI actually revert to normal cognition in longitudinal observational studies.
Really? They just get better.
The diagnosis can be unstable. An underlying depression might have been mimicking MCI or a vascular issue stabilized.
Which makes treating MCI incredibly difficult, ethically and practically.
Immensely difficult. Currently, there is absolutely no robust long-term evidence that the standard cognitive enhancers we use for Alzheimer's dementia, such as the cholinesterase inhibitors like donepezil or rivastigmine, actually reverse or even definitively stop the progression of mild cognitive impairment. Prescribing them is often an exercise in clinical hope rather than evidence-based medicine.
But the pharmacological landscape is undergoing a violent shift with the advent of biologics. The textbook sources mention the highly controversial FDA approval of aducanumab in 2021. This feels like a turning point.
It is a turning point, but a fraught one. Aducanumab is a monoclonal antibody. It is an engineered immune protein specifically designed to cross into the brain, bind to beta amyloid plaques, and trigger the immune system to clear them away.
So it acts as a highly targeted cleaner.
Right. It was approved for patients in the early stages, specifically those with MCI and mild dementia due to Alzheimer's pathology.
But it is highly debated within the psychiatric and neurological communities.
Intensely debated. The data shows that the drug is highly efficacious at its biological task. It clears amyloid from the brain remarkably well on follow-up PET scans. However, the actual clinical and functional cognitive benefits for the patient are considered, at best, modest.
Modest benefit, but what about the risks?
That's the catch. This modest benefit comes with significant, sometimes life-threatening risks, specifically a phenomenon known as ARIA amyloid-related imaging abnormalities.
Breaking that down, ARA means?
ARA manifests primarily in 2 ways. ARAE, which is vasogenic edema or swelling of the brain tissue, and ARAH, which represents microhemorrhages or tiny diffuse bleeds within the brain parenchyma.
Why does it cause bleeding?
Because amyloid also deposits in the walls of the blood vessels. The mechanism of clearing the plaque out of the blood vessels inherently damages the vessel walls. So the clinician is forced to walk a high-stakes tightrope, weighing a potentially modest slowing of memory loss against the very real risk of literally causing the patient's brain to swell and bleed.
It's a profound balancing act of medical ethics and clinical judgment, which leads us perfectly into distilling everything we have explored today into our key takeaways. To consolidate our own mental libraries, what are the fundamental, unshakable clinical pearls the listener needs to walk away with?
I would distill the chapter into 4 core actionable concepts. Number 1, Mild cognitive impairment is defined not simply by objective, measurable cognitive decline on a test like the MoCA, but by the preservation of independent daily functioning.
So function is the dividing line.
Yes. The moment a patient loses the capacity for independence, regardless of their test score, they cross the clinical border from MCI into major neurocognitive disorder or dementia.
Number 2.
The ATN framework is actively shifting the field from syndromal definitions to biological definitions of disease, tracking amyloid, tau, and neurodegeneration. However, clinical mimics like late, which is driven entirely by the misfolding of the TDP-43 protein, not amyloid, prove that divergent microscopic pathologies can perfectly mimic the outward clinical syndrome of Alzheimer's.
Number 3.
Amnestic disorders are highly selective. They selectively destroy episodic memory, both anterograde learning and temporally graded retrograde recall, while entirely preserving implicit procedural learning, immediate working memory, and attention. This selectivity maps to distinct, localized structural damage, usually in the medial temporal lobes or the diencephalon.
And finally, number 4.
Thiamine deficiency, most commonly driven by chronic alcohol use disorder and Wernicke-Korsakoff syndrome, fundamentally disrupts the brain's ability to metabolize glucose. This energy failure triggers NMDA excitotoxicity, leading to irreversible necrosis in the mammillary bodies and diencephalon if it is not identified and treated aggressively with intravenous thiamine during the acute encephalopathic phase.
Excellent. Now, to truly lock in these mental models, we are going to move into our learning reinforcement section. We are going to conduct virtual clinical rounds. I will present a single best answer clinical scenario, think through the differential diagnosis, and then we will break down the expert clinical reasoning. Let's put this into practice.
I'm ready for the first case.
Question 1. A 72-year-old patient presents to your clinic. She demonstrates objective, measurable memory impairment on neuropsychological testing, scoring a 22 on the MoCA. However, during the clinical interview, her daughter confirms that she continues to entirely independently manage her complex finances and a multi-pill medication regimen. The daughter notes, however, that her mother has had to implement an extensive, rigid, color-coded calendar system to achieve this, which she never needed before. Based on DSM-V, what is the most appropriate diagnostic classification for this patient?
The correct classification here is mild neurocognitive disorder, encompassing MCI. The clinical reasoning hinges entirely on the functional independence axis. The patient has documented objective cognitive decline, fulfilling the first criteria. However, she retains the capacity to manage complex instrumental activities of daily living. The critical detail is the color-coded calendar system. That is the hallmark environmental accommodation or greater effort we look for in MCI. Because her independence is preserved, even if scaffolded, she remains out of the major neurocognitive disorder category.
Perfect. Let's move to question 2, focusing on biomarkers. Within the ATN framework, a patient undergoes a lumbar puncture and CSF analysis. The results reveal abnormally low levels of A-beta-42. However, they have entirely normal tau levels, and an FDG-PE scan shows normal glucose metabolism with no hypometabolism. What does this specific biological profile suggest about their clinical progression risk over the next 3 years compared to someone who is positive for neurodegeneration markers?
This specific profile, amyloid positive, tau negative, neurodegeneration negative, suggests a remarkably slower risk of clinical progression. As we explored through the paradox of plaque, beta amyloid is considered necessary but not sufficient to produce the rapid cascade of Alzheimer's dementia. Patients harboring only isolated amyloid deposition progress at a noticeably slower, more indolent rate than those exhibiting downstream markers of active neuronal death, like elevated tau or structural hypometabolism.
All right, question 3, diving into the pathology lab. An 84-year-old patient presents with a progressive, severe amnestic dementia syndrome that clinically is utterly indistinguishable from classic Alzheimer's disease. They eventually pass away, and upon post-mortem neuropathological autopsy, researchers are stunned to find an absence of significant amyloid plaques and neurofibrillary tau tangles. Instead, the staining reveals widespread toxic clumps of TDP-43 protein and severe hippocampal sclerosis. What emerging diagnostic entity best describes this exact presentation?
This describes late limbic predominant age-related TDP-43 encephalopathy. This scenario is the classic textbook manifestation of suspected non-Alzheimer pathology, or SNAP. It reinforces the crucial clinical concept that severe amnestic dementia in the oldest demographic can be driven by the misfolding of entirely distinct RNA-binding proteins, completely separate from the classic amyloid cascade.
Question 4, an acute presentation in the emergency department. A patient with a 25-year documented history of severe alcohol use disorder develops a profound, sudden inability to form any new memories. During the psychiatric interview, he is highly engaging but frequently invents elaborate, physically impossible stories to explain his whereabouts over the last week, demonstrating zero awareness that his memories are false. An urgent MRI is performed. Which specific diencephalic structures are most likely to show acute microhemorrhages or chronic atrophy?
The MRI would definitively target the mammillary bodies as well as the medial dorsal nuclei of the thalamus. This is the classic, tragic presentation of Korsakoff syndrome, the chronic phase of severe thiamine deficiency. The profound anterograde amnesia coupled with the florid confabulation points the anatomical arrow directly towards diencephalic lesions and the disruption of the frontal reality monitoring networks, cleanly separating it from a pure hippocampal amnesia.
And our final case, question 5. Following a severe acute case of herpes simplex encephalitis, a patient miraculously survives but is left with devastating neurological sequelae. He retains his extraordinary ability to play complex classical piano concertos beautifully. However, he cannot remember a single detail of a conversation he had just 5 minutes prior. In this precise scenario, which specific memory systems are impaired and which neuroanatomical systems are preserved?
In this scenario, mirroring the famous Clive Waring case, explicit or declarative episodic memory is profoundly impaired. This deficit is directly due to the viral hemorrhagic necrosis selectively destroying the medial temporal lobes and hippocampi. However, his implicit procedural memory, the deeply ingrained motor memory of playing the piano, is fully preserved, as those robust pathways reside safely in unaffected anatomical areas like the basal ganglia and the cerebellum.
Brilliant diagnostic reasoning. Thank you all for joining us as we explored the shifting, uncertain corridors in the library of the mind. To fully integrate these models, we highly encourage you to review the source textbook chapter in tandem with this discussion.
But before we officially close the book today, I want to leave you with one final, deeply provocative thought to mull over during your next clinic. We briefly touched upon the Rush Memory and Aging Project in the sources. When researchers finally looked at the autopsies of the aging brains in that massive cohort, the data revealed something astonishing. Half of the participants had TDP-43 pathology.
Half of them?
Yes, and roughly 37% had both TDP-43 and Alzheimer's amyloid pathology coexisting in the exact same brain.
A completely mixed bag. The arsonists were working together.
Exactly. The provocative thought is this. Perhaps the entire century-long history of psychiatry and neurology has been overly, almost blindly obsessed with finding pure diseases. A pure Alzheimer's case, a pure Lewy body case. When in reality, the hard data suggests that mixed, overlapping pathologies are the absolute norm in the aging human brain. And if that is true, how does that fundamentally change the way we approach future pharmacological treatments? Because if no single magic bullet can possibly fix a mixed, multi-protein pathology, are monoclonal antibodies targeting just one single protein ever going to be enough to save the library?
Something vital to think about as the field evolves. Here are the details of this episode.
Mild cognitive impairment and amnestic disorders. Byline. Sometimes the first clue is not a lost memory, but the growing awareness that memory is no longer as reliable as it once was.